Hello and welcome to all of our online participants. It is now 9 a.m. here in Copenhagen, and it's time to kick off the fourth Nordic Conference on Sustainable Healthcare. So this year's conference is arranged by the Swedish foundation Nordic Center for Sustainable Healthcare, or NCSH for short. This is done in collaboration with the Danish Technical University in Copenhagen, Upgraded in Finland, Healthcare Without Harm, the Capital Region of Denmark, the Swedish Energy Agency, and Nordic Innovation. My name is Felicia Matz, and I'm part of the NCSH team, and I will be moderating this introduction plenary. Before we begin, I will just shortly go over a few practical details. This conference will go on until 4:30 p.m. Central European Time, and during the day we will have a number of parallel sessions which you can join in accordance with your preference. You will find all the sessions in the Deal Room platform under Program, and you will also be able to meet and interact with other participants during the day through our networking platform. Without further ado, I would like to present the first speaker of today, Kondo Steffensen, who is the Program Director of the Danish Technical University. Welcome.
Yep. Thank you, and good morning, at least good morning from the Copenhagen time perspective. My name is Sam, and I'm from DTU, the Danish Technical University, and the Danish partner in this project. And I will just shift now to full screen. But I would like to welcome you all for this conference and also tell you that we are seriously missing you here. We had planned a major conference with a lot of interactions, but due to these turbulent times, we have this online format, and I hope that you will enjoy that as well. Yes, as Felicia mentioned, we have a 7-track program for you today with a lot of amazing speakers, which I would like to thank for joining in here. Let me just explain a bit about the backdrop of this initiative here. What we see right now is actually a growing impact and importance of sustainable healthcare on a global scale. And one of the sort of drivers for this sort of growing impact and importance is kind of unprecedented technology influx. We see technology moving into the healthcare space in many sort of ways. And we see technology actually taking up, it's consuming a lot of power, but it's also presenting a lot of opportunities. So it's also something about, the cost perspective and the interaction perspective between technologies in the healthcare sector. So technology is a main driver for a lot of the sustainability opportunities and the challenges. We also noticed an enlarging concept of healthcare. So healthcare is going from traditional sick care to more look at the health perspective. It's moving into the primary sector in many ways, and it's now also being part of a lifestyle, nutrition, everything related to lifestyle issues and prevention. So healthcare in itself is an enlarging concept that in that way also have a growing impact on a societal level. Thirdly, I would just like to mention that healthcare is an ever-growing sector globally right now. There's a growing healthcare industry, and there's a growing expectation among all populations toward healthcare services as such. So in that way, healthcare becomes a really very central part of any kind of societal sort of system, and in that way also a sector that needs to be addressed from a sustainability point of view. And let me just mention a few of the actionable perspectives that we see from our line here. And one is that we are in a capability actually to activate the public procurement muscles, especially in single payer systems procurement in itself can play a major role in actually sort of facilitating the transformation to more kind of sustainable and resilient healthcare sectors as such. So public procurement in itself can play a vital role in sort of promoting more kind of sustainable solution, simply also by sort of requiring these solutions in the system. Secondly, I think that the whole measurement, the impact and effect measurement of sustainability is a very important component these days. We all know what get measured get treasured. So the way of actually, finding reliable measures of impact, both in the sustainability field, but also in sort of the healthcare perspective at the same time, is crucial, and where all parties sort of can buy into these kind of models. It's very important that we find, really measures for progress in the sustainability field. Thirdly, I think that there is an opportunity here to create an activity field for startups, for specialization and research and entrepreneurship. There will be a lot of research fields that can be promoted at university level and in higher education, and there's definitely a field here for new entrepreneurship and specialization in many ways. And I think a lot of our startup environments should address the sustainability part right from the beginning of setting up a business, because again, it also relates to the procurement situation, that they can actually differentiate themselves by, having a clear sustainable profile in their business. So this is definitely an area where there's a new business field emerging. Thirdly, I think that it's very important to secure and maintain a systemic approach insofar as the healthcare provisioning system in itself is a huge sort of a system, and it interrelates in many ways, and we see it moving into to people's home, and it also encompasses a lot about transportation, logistics, and so on. So whatever sort of field you're in, it sort of requires a systemic approach, and I also think it requires dedication and responsible mindsets. So rather than being a new kind of administration, I think that a lot of these new sustainability initiatives should be driven by dedicated and responsible mindsets, as we also will see during the day that we will have a lot of examples of successful implementation of sustainable solution driven and led by responsible and dedicated individuals. So with that said, I would say thank you for joining us today, and leave the floor for Daniel, who will be our next speaker here. So, but thank you for attending today, and we will be looking forward to seeing you for real in next year at the conference. So thank you.
Thank you very much, Sam, for that presentation. So I will now introduce our next speaker right here, Daniel Eriksson, who is the founder and director of Nordic Center for Sustainable Healthcare.
Thank you very much, and welcome to this conference. And we say thank you very much to DTU for hosting it for us, even if it's online this year and not at site. But we at Nordic Center, a few of my colleagues are here today in Copenhagen, and just managed to get over. There was a little bit of a more lockdown here yesterday, so we are quite alone here at the big Danish Technical University. The Nordic Center for Sustainable Healthcare is run by a foundation called TEM. It was founded by Lund University and a few municipalities back in 1984. We are something so unusual as a self-funded foundation, so we don't get any annual grants or so. We earn our income ourselves in different ways with projects, consulting, trainings, and different member fees. And today we have over 220 members in total in our two networks. This is one of our networks. CSR Skåne is more regional CSR network focusing on sustainability in a wide sense. But as you can see, there's some quite international, well-known companies are part of this. But today I'm here to talk about Nordic Center for Sustainable Healthcare. Our motto is to raise the status and awareness of sustainable healthcare. We want to boost innovation and investment in sustainable healthcare. We want to bring world-class solution ideas to Nordics, and we want to deliver Nordic solutions and knowledge to the world. We actually have a celebration this year, a 5-year celebration. We started 5 years ago due to the fact, as you can see here, we think there are so many good things happening within sustainability in healthcare that too few people know about. There is a huge possibility to expand this to other countries, to other hospitals, to other regions. There's so many good solutions that needs to be spread. When we started this network 5 years ago, we also thought that we need to include all the stakeholders within sustainable healthcare. A lot of other networks and clusters focus on only parts of the whole value chain. But I think the NGOs are very important to include the state, the enterprises, the university, public healthcare, private healthcare, and development in different ways. So we need to bring all these different stakeholders together to make progress faster. We also think that sustainable healthcare is something is horizontal. It's kind of a new industry that's horizontal over the old industry. So sustainable healthcare is not medtech or life science or clean tech, but it's clean tech with applications for healthcare. It's medtech and life science with good environmental performance. It's architecture when you design sustainable hospitals. It's management in different ways. So what we're trying to do is to create a new industry, horizontal over the old industry. And this is also a new innovation area, a new research area, etc., where we need to link those different companies in these different fields together. Today, we're very happy that during Corona, we have actually expanded our network the last 3 months by 11%. So we are over 115 members now. We have members from India to US, Canada, and I think we also got members now down in New Zealand and all over Europe. So Nordic is an understatement today. We have members from almost all over the world. We function as some kind of an umbrella organization. We, together with our members and other partners, create projects and different development or innovation platforms or delegation and those kinds of things. We do some publications, well, both academic, but also more focus on different areas, like the white paper on Nordic sustainable healthcare, the focus on why the Nordics are world leaders in this, as we claim we are. And you can listen more on that later on this afternoon, that I will explain why we think the Nordics are world leaders in this. But we also have a lot of publication focusing on specific areas like geothermal energy or nitrous oxide gas cleaning and those kinds of things. And here, during this Corona, we have started a new line of reports that are very narrow and specific and focused on one issue. We have completed 3 ones so far on nitrous oxide destruction, geothermal energy, and next week or so we will release the 3rd one on lighting. And this will be a series of reports focusing on solutions in the Nordic countries and those technologies that are involved. So we are aiming for 7, 8, 9 different Nordic know-hows a year, actually. So if you have an idea on a specific theme you want us to focus on, so do please contact us. Don't forget to check out our webpage, nordic.shc.org. There's a lot of things happening, trainings, webinars, workshops, delegations, and all kinds of things. So sign up for newsletters and check our webpage. I also want to take the opportunity now to invite you to the to the 5th Nordic Conference on Sustainable Healthcare that will also take place here at the DTU May 11. So we're hoping that some of the speakers and exhibitors and sponsors will follow us and do this live at DTU in Copenhagen, May 11th. And this will be the 5th Nordic Conference. The first 2 we had in Stockholm, the 3rd one in Finland, and this is the 4th one we're doing now online. So we're hoping to do the 5th one live with all our colleagues from all over the world that place here in Copenhagen, May 11th. If you do have any questions, don't hesitate to contact me. Thank you very much, and welcome to this conference.
Thank you very much, Daniel, for that presentation. Our next speaker is a keynote speaker of today. Her name is Dr. Rosemary Kumwenda. I would like to welcome you to share your screen and begin your presentation.
So thank you very much, and thank you for the invitation for me to share the Sustainable Procurement in the Health Sector initiative and to discuss why sustainability is at the heart of the health sector. So my name is Rosemary. I lead the UN Sustainable Procurement in the Health Sector initiative, but also coordinate the Sustainable Health in Procurement project, which I'll describe in a bit. In terms of my presentation outline, I would like to share why sustainability in the health sector is important, and I'll touch briefly on the initiative for the United Nations, which is the SPHS, and also the CEDA-funded project, which is the SHIP. And I'll share also, lastly, the resources that we have developed, but also what we are currently working on. So just as a matter of interest in terms of what we're discussing today, sustainability in the health sector, and why sustainable health, sustainability in the health sector is important. I think we all know that if the health sector were a country, it would be the 5th largest emitter of greenhouse gases on the planet. And this is a study that was conducted by our partner, Healthcare Without Harm, on the healthcare climate footprint report conducted by ARUP. So the UN, including the work on sustainable development goals, the health sector becomes one of the greatest entry points, because for us, we purchase a lot of commodities for the health sector. And this area of products can contribute to greenhouse gases, including issues of packaging and transportation. We find that there's significant impact on the health of people, but also on the health of the planet. And if health can be the lead in ensuring that we mitigate the negative impact of climate and protecting people and the environment, it becomes really a connector of other sustainable development goals. Moving on then to UN Sustainable Procurement in the Health Sector, the SPHS initiative, which I discussed earlier on as a topic for presentation and sharing. Way back in 2012, the UN realizing that we are buying quite a number of commodities for the health sector, and on behalf of governments, we are spending between $3 to $5 billion per year. This, in our view, is a very sizable portion of the global pharmaceutical and other health commodities market. And we have some financial resources to contribute if we aggregate the demand of the UN agencies. So we formed this initiative, which is really informal, but informs the formal aspects of UN response and support to achieving sustainable development goals. So currently 10 UN agencies form members of the informal interagency task team on sustainable procurement in the health sector. They include UNOPS, UNICEF, UN Environment, UNDP, UNFPA, UNHCR, the WHO, and 3 financing institutions in the health sector, the Global Fund, UNITAID, and Gavi. And this is really, really important that we in the UN and with international financing institutions put our heads together to forge the agenda of sustainability in the health sector, but also to try and use common principles for procurement that are important for the UN. And they include ensuring that we get the best value for money, ensuring that there's fairness and transparency and integrity in procurement, and ensuring also effectiveness in international competitiveness, and to ensure that the UN's interest is adhered to. So we try as much as possible to use the UN Global Compact principles. What then do we do as the UN SPHS? We try and work at a multi-level perspective, ensuring cross-cutting innovations, to try and drive change in the health sector, being inclusive and focusing on market intelligence. We have set ourselves an engagement platform, which is the SPHS engagement platform, focusing on the 11 key areas that include chemicals. We focus on energy, gender equality, human rights, packaging, resource efficiency and transportation, waste management and water efficiency. And so we try as much as possible to bring in the environmental and social dimensions of sustainability into procurement. There is one important aspect of sustainability that we are forging with UNEP, and that is being a member of the One Planet initiative, so that the health sector, which was initially left out of the UNEP strategy, in the new strategy, we have a health pillar that is being co-led by UNDP and Healthcare Without Harm. So why have we partnered with UNEP on the One Planet network is to ensure that the sustainable procurement in the health sector falls under the auspices of Sustainable Public Procurement Program of UNEP. And the One Planet initiative is a very good entry for bringing in global partners so that we work together to enable discussions, exchange of knowledge, practices, and also a wider uptake of sustainability practices in the health sector. And hence, we developed jointly with Healthcare Without Harm a project which is called Sustainable Health in Procurement. So that is to make sure that when we procure the amount of resources that are put into health procurement in the UN, the overall, what we know, the overall procurement from the UN, 75% of UN procurement is health procurement. So this project, which we mooted jointly with Healthcare Without Harm and is funded by CEDA, is focused in 10 countries, and it's a global project. So the countries were pre-selected based on the fact that Healthcare Without Harm already had initial programs on health and environment, focusing on global green and healthy hospitals. And they selected the emerging market countries such as China, South Africa, India, and Brazil. And the other countries where UNDP then is the lead, there are 6 countries. They include Zambia, Tanzania, South Africa, Vietnam, Argentina, Moldova, and Ukraine. So the reason we selected these countries, we already had some prior connectivity between health and environment programming. And so we came up with a development objective to promote sustainability in the health sector supply chains, to improve human health, and to reduce greenhouse gases, resource depletion, and chemical pollution. So we are really focusing on these 3, greenhouse gases reduction, reduction of resource depletion, and chemical pollution. The project ends next year. It's been a 4-year program, and we have now reached like the midterm of the program. So the rationale and the selection that I talked about is ensuring that there is adherence to international commitments in these 10 countries, and governments and health systems are being supported to foster sustainable procurement in the health sector. And so we engage with both upper middle income countries, developed countries, and low income countries. So the good mix enhances connectivity and sharing of good practices. So the health supply chains have to move the supply chains towards a model that prioritizes environmental sustainability, human rights, poverty reduction, child protection, and gender equality. These are important mixes between the social dimensions and environmental dimensions of sustainability, rather than focusing on the price only when considering procurement of health commodities. Most of our procurers, that was initially the criteria to look at the lowest price. But now value for money entails that we need to look at the whole life cycle of a product. Like I mentioned, we have 4 objectives in this project. One is to develop a universally adaptable criteria and standard for sustainable procurement, which doesn't exist at the moment. And we are working with ARUP, developing an index that will ensure that we have an adaptable criteria for sustainability in procuring of health commodities globally. Secondly is to foster sustainable procurement in the health sector by developing capacity of procurers. And then thirdly is developing capacity jointly of producers of health commodities. And then we need to measure the success and impact of this project. So our envisaged outcomes are that at the end of the project, we would have made strides in ensuring that we have focused on hazardous chemicals to remove them from the health sector. And we have made strides in reducing greenhouse gases and chemical pollution or conserving resources in the project countries. And obviously, we align our actions to the Sustainable Development Goals and also institutional strategies, both in Healthcare Without Harm and the UN, but also with our donor, the Swedish Development Agency, ensuring that the results of these 3 strategies are interlinked to ensure that the basic health of people, but also the health of the planet, are safeguarded. Lastly, then, let me share with you some of the resources that we have developed. We have worked with Healthcare Without Harm to develop the Sustainable Health Procurement Guidance Note, which was launched this year, and it's being moved into a online training guide for procurers, but also interested parties outside the United Nations will be able to access this online certifiable training, and we're working towards that. We've also developed an engagement with suppliers and manufacturers on sustainable production and disposal of health commodities. Disposal aspects are also critically important. We had all our principals in the 10 agency members commit to us that we should engage as technocrats with manufacturers of health commodities. And in that regard, for the past 2 years, we've engaged with manufacturers in Manufacturers Forum, starting from Asia, then we went to Africa, and this year we will be in the Arab states in Saudi Arabia in October, hosting the Global Manufacturers Forum of Health Commodities. It was supposed to be alongside the G20 summit, and what the Saudi Food and Drug Authority has committed is that with or without the G20, the Manufacturers Forum on Sustainable Procurement in the health sector will go ahead in October. So stay connected with us to hear more about this Sustainable Procurement Forum for manufacturers. So we continue to engage with suppliers to stimulate their participation and to ensure that when we launch bids, they have sustainability criteria, both environmental and social dimensions of sustainability. We would also like to ensure that we're not leaving anyone behind, so small, medium, and large enterprise are all included so that they are not disadvantaged groups in sustainability in the health sector bids. We also developed a monitoring of compliance with international environmental conventions on chemicals to make sure that chemicals are removed from the health sector. And we focused on promoting conventions, international conventions such as Stockholm, Minamata, Vienna, Basel, and Rotterdam conventions. And so these are now being integrated in the index that we are developing with ARUP. We also have an environmental questionnaire for suppliers and manufacturers of health commodities. It helps them to set their own baseline and a level of ambition to integrate sustainability in their production and also in the supply of health commodities. Dear colleagues, this is where my presentation ends, and I hope we have been able to share with you snippets of what we are doing in the sustainable procurement space. But sustainability in the health sector requires a multi-sectoral approach. It requires international partnerships. It requires global commitments. And I think while we have, clusters of partners everywhere working on sustainability initiatives, such as what the Nordic group has done today to bring us together, will help us to forge sustainability more globally and to ensure that all countries, developed and least developed, move together towards a sustainable global health. I thank you.
Thank you very much, Rosemary, for that presentation. Very interesting. So with that, I would like to present our next keynote speaker of today, which is Dr. Jodi Sherman. So Dr. Jodi Sherman is the Associate Professor of Anesthesiology at Yale School of Medicine, and she is an internationally recognized researcher in the emerging field of sustainability in healthcare. So welcome, Jodi.
Good morning. Can you hear me?
Yes, we can hear you fine. Thank you.
Oh, fantastic. Well, thank you so much for the invitation to speak. I am a practicing anesthesiologist as well as a researcher in healthcare environmental sustainability, specifically working with environmental engineers to quantify environmental impacts. I'm really grateful for Dr. Kumwenda's talk. It does cover things I will not be talking about, including social impacts. So really grateful for her presentation. I practice in New Haven, Connecticut, which is in the northeast of the United States, very close to New York City. So New Haven is here, New York City is here, and the Yale New Haven health system is all across the Atlantic coast here in the state of Connecticut and actually into Rhode Island and parts of New York. We were very much affected by the first wave of the COVID pandemic as it struck New York City. And being on the Atlantic coast, we are also very vulnerable to hurricanes, storm surges, sea level rise. So there are a lot of similarities. I'm sure this audience has already made connections between the COVID pandemic and climate change in terms of both supply chain vulnerability and really resiliency strategies. And so what I hope today is to make some of those connections. And by the end of the talk, I hope you'll be able to describe some healthcare environmental emissions, discuss what life cycle assessment is, and give some examples specifically applied to reusable and disposable medical devices, review some supply chain vulnerabilities, and identify some sustainability solutions that improve both supply chain resiliency and reduce emissions. For anyone who uses social media, my Twitter handle is @GreeningDoc. Some suggested hashtags include the climate crisis, COVID crisis, sustainable healthcare, and I do have nothing to disclose. So perhaps this is nothing new to this audience, but it bears stating we must ask the question, why sustainability in healthcare? You know, pollution is a leading cause of morbidity and mortality globally, responsible for 9 million premature deaths annually, or 16% of all premature deaths are due to pollution. Healthcare itself is a leading emitter of environmental pollutants, which goes against our mission. So reducing healthcare pollution can improve the quadruple bottom line, which was, usually we hear about the triple bottom line, which is what's best for patients, also public health at the least costs. And the fourth dimension that is staff satisfaction. Staff really do care about doing what's best, and that includes environmental sustainability. And that this really, healthcare sustainability is really an opportunity to engage industry, the healthcare industry. Is connected to all dimensions of society. And so focusing on healthcare sustainability will have impacts both in public policy and societal transformation. So it's certainly what I think is one of the most important issues of our day. So globally, healthcare is one of the largest industries in the world. And it is unfortunately also one of the biggest emitters of pollutants. This talk will focus most essentially on greenhouse gas emissions, but it's not the only pollutant of concern. So globally, healthcare is responsible for about 4.4 to 4.6% of total global emissions. And unfortunately, the US is an outlier here. That's probably not a surprise to the audience. And being from the United States, I will have a particular US bent on this talk, so please forgive me for that. And so per capita expenditures and also per capita greenhouse gas emissions, the United States is responsible for nearly a quarter of all healthcare global emissions per capita. Overall. And the trend is going up. And even in the Nordic states, based on this modeling, the trends are going up. And part of that has to do with population, and part of it has to do with technology development, and part of it has to do with the nature of the models. But the point is that healthcare emissions are rising, and they're substantial, and we need to work harder to try and curb them. In terms of relative emissions, numerous studies have shown that between 60 and 80% of healthcare's emissions stem from the supply chain, especially from energy and upstream manufacturing. So that is an important area to address. Healthcare administrators and clinicians control which and how many of supplies that we use. Manufacturers control what's embedded in those emissions and ultimately what makes it to the marketplace. This is a famous widget that was initially presented by the Sustainable Development Unit of the National Health Service in England, who's been leading the world with the longest consecutive analysis that has been publicly available and national supported project to measure its healthcare emissions, and has recently made a commitment as a nation for its National Health Service to go to net zero. So healthcare resource consumption is a problem. We mentioned that globally it's a substantial fraction, nearly 5% of our global emissions come from healthcare. It's 10% of our global economy. And hospitals are very energy intensive buildings, 2.5% the energy of commercial sized buildings. And this is pretty standard in wealthy nations. Hospitals run 24/7. High-tech diagnostic therapeutic equipment. What you're seeing here is a picture of a robotic abdominal surgery. This is the robot here, which it's actually being operated by a surgeon who's sitting in the corner here, and this is the assistant. And all the linens here, both what the operator is wearing and what are on the patient, are single-use disposable. These instruments that are in the patient, these complex surgical instruments, are also single-use disposable. There's this unique infection prevention requirement in healthcare, unique risks, and then a complex regulatory environment and business models that drive wasteful and unnecessary utilization of resources. And particularly in Western countries, we have a culture that is very high-tech oriented, and is excessive, and disposability is normalized. So really the crux of this is infection prevention, right? So everything we do in healthcare is through the lens of patient safety, and that means especially prevention of infections. So this is very fundamental to everything we do in healthcare, and I would not suggest otherwise. Healthcare-acquired infections are the most frequent adverse events in healthcare delivery worldwide. Hundreds of millions of patients are affected globally, leading to significant disease burden, deaths, financial losses for health systems. Of every 100 patients, 7 in the developed world and 10 in developing world suffer at least one healthcare-acquired infection. In high-income nations, this is most commonly urinary tract infections, where in developing nations it's surgical site infections, but both are problems globally. And this lens of trying to prevent healthcare-acquired infections is driving this trend towards single-use disposable devices, especially in high-income nations. And let's be clear, prevention of healthcare-acquired infections is essential. However, much of this trend towards single-use disposables is not evidence-based and has untoward side effects. So this is a famous paper from the Annals of Surgery that basically reviews the history of surgical site infections, one type of infections. If we go back in time, for example, to the 1800s, it used to be if you had a major surgical procedure, for example, a limb amputation, you had about a 95% chance of getting an infection and about a 40% chance of surviving that procedure. And where you see this very large, decrement over time, that's where we start to see semmelweis pastoralist, or essentially the development of sterilization aseptic procedures. So this is the largest decrement we see in infection rates and the largest improvement in survivals. And where you see this next dip around the 1930s, 40s is where we see the introduction of antibiotics. So those are the two greatest contributions in human history to reduction of infections and improvement of survivability. So now we're down to, at least in wealthy nations, about a 5% or less surgical site infection rate, and better than a 95% survival rate. And so we are there's a quest to have zero infections, which is a laudable goal. But if we look at that part of the graph, as we're asymptotically approaching zero, we're throwing more and more disposable devices at the problem, and then there's this unseen risk of indirect disease burden from healthcare pollution that is on the rise. And this has been hidden from view, and this is a new area of work, and this audience is very astute and aware of these things, but it is not commonly considered. Historically, it's been this black box. So we can no longer ignore this hidden impact on public health. And we have to really question it if getting to zero healthcare-acquired infections is realistic. So causes of infections are multifactorial. They include the need for staff discipline, most notably hand washing, patient health status. So patients who are immunocompromised, most notably in Western countries, diabetes is an immunocompromised state. The exposure site, whether it's a clean area or a dirty area, the number of organisms and how virulent they are, whether or not patients get any or the correct antibiotic, and then the design of the environment, including access to clean water and protective devices, including air handling devices, gloves, and so forth. So of all these dimensions that go into infection control, the most important thing we need to pay attention to is hand washing. And these are things that are not going to be solved through throwing more and more disposables at the problem. And so our supplies are produced globally through many layers of manufacturers, from raw material manufacturers to components being manufactured at locations all over the world, to where they're ultimately assembled, or the tier 1 suppliers, which are the ones that get us direct to the users. Globalization, in many regards, is a wonderful thing. It supports economies all over the world, can reduce production costs. Also, we have this phenomenon of just-in-time delivery, which, as we consume more and more disposable devices, we need to replenish them more frequently, and to be able to do so with modern transportation shipping can reduce storage costs and expiration dates on products, or expiration, not the dates, but the actual expirations. But there's lack of transparency, and particularly of the risks of these suppliers to all sorts of vulnerability, whether it's COVID or climate change. And so as the world has abruptly suffered this supply chain shock from COVID, and particularly a lot of our devices, notably PPE, the vast majority of which are manufactured in China. And of course, when populations are abruptly ill, they cannot go to work to make the supplies that we consume. And then there's this problem of closed borders, so interruptions to transportation by air, by ship, by rail. And so these interruptions have dramatically impacted our ability to acquire these supplies. But it's not just obviously from COVID. In terms of climate change or pandemic, in terms of climate change, weather-related disasters also disrupt healthcare services. This is from the United States. I mentioned along the Atlantic coast, where we have hurricanes every year. Hurricane Sandy is one that made headlines in 2012. We have hurricanes every year. This one was quite famous for flooding New York City, and I believe this is actually in New Jersey. But this is famous headlines from Langone Medical Center, where patients were evacuated in the middle of the night by flashlight. And here we see nurses, teams of 6 and 7, having to bring down neonatal patients, critically ill patients on life support. And so these are some famous images of them being evacuated to another facility, which had to ultimately be evacuated several days later. The campfires or the wildfires in California are another unfortunately recurrent issue. This is a famous, the Camp Fire was famous in 2018. This is another hospital that is being evacuated and was subsequently decimated. So Hurricane Maria in 2017 destroyed or devastated much of Puerto Rico, which is off the southeast coast of the United States, one of the United States territories. It turns out that that's where a majority of some of our drugs and saline solutions were manufactured. And so nationally, we're suffering from critical shortages, having to make substitutions of drugs, which can lead to errors, inappropriate or ineffective therapeutic substitutions, improper handling of drugs intended for single doses or single patient use, and oftentimes with no alternative medication available. And there is this odd phenomenon of increased drug waste. What you see here is 2 different preparations of bupivacaine, which is a local anesthetic. This is a 2 ml vial, which is commonly in our kits for doing spinal anesthetics, which we do for women who are having surgical deliveries or cesarean sections. On the left is a 30 ml vial preparation. So when the 2 ml vial ran out, we were substituting 30 ml vial preparations. And without appropriate infrastructure, it is very dangerous to try and split these drugs. And so we had this phenomenon where despite national shortages, we were routinely throwing away 95% of our drugs. And so that is an unfortunate complexity of our system. So certainly personal protective equipment or PPE has made global headlines with the pandemic, with the COVID pandemic. There have been shortages. On the left is a picture of some nurses from one of our hospitals in Brooklyn, New York. And on the right is from a hospital in England where garbage bags are being used on the left in gowns and on the right for head coverings. These are, PPE is certainly famous for its shortages, and that includes surgical masks and respirator masks or the N95s, also face shields, surgical gowns, impermeable gowns, and gloves and goggles. So these are all on shortage. But other things, critical supplies are on shortage. You certainly heard of ventilators being on shortage. video laryngoscopes, which are the blades that we use to see where we're going to put our breathing tube for patients that are going on ventilators. Drugs used for sedation for patients who are on ventilators who are in critical shortage. Dialysis supplies, so renal failure is one of the most common consequences of critically ill patients with COVID. Those were on supply. And, we were making life and death decisions here in the United States, in Lombardy, Italy, based on whether or not we had availability of supplies, which is something we don't experience in the developed world, this idea of shortage. It turns out that we actually are always on shortage. We just don't perceive it. So a lot of measures that have been in place acutely in the COVID pandemic shouldn't be just in times of shortage. They should be times always. There's this concept of a burn rate calculator. This one was produced by the U.S. Centers for Disease Control and Prevention. So basically, we become so dependent on single-use disposable PPE that we were running out. Healthcare workers were getting sick, and many of which have succumbed. So in this calculator, you can look at your daily inventory for those 5 critical supplies: gowns, gloves, surgical masks, respirator masks, and face shields, all of which are predominantly single-use disposable. And based on how many patients are being treated, both suspected and confirmed, you can project how many days you have of your supply. And based on that information, make emergency procurement and also extended use decisions which are outside the usual standard of care. So I'm just going to switch gears and talk about how we do environmental emissions assessment. This is using an environmental engineering tool called life cycle assessment. This is how we quantify total resource inputs and the environmental burdens over the life cycle of a product. We tend to think about things when we use them or when they're distributed. We tend to think less about what goes into the manufacturing of those devices or materials, including raw material extraction. And mostly we tend to think what happens when we throw things away. But you really have to consider the entire life cycle to understand those impacts, whether they're social impacts, environmental impacts, cost impacts. So the entire production system needs to be considered. It's not necessarily intuitive where those emissions are. For example, in the cases of inhaled anesthetics, it's throwing them away. They typically are discarded directly to the environment where the impacts are. For many of our devices, it's the material extraction and the manufacturing process. So we have to consider multiple impacts. It's not just carbon emissions, although we talk predominantly about carbon emissions, and we have to make sure that we're not simply trading off or shifting burdens from one impact category to another. And this type of information is used for both design and procurement and clinical selection, so decision support. In the case of medical devices, we also have to think about infection risk. So devices are categorized according to how sterile or not sterile the tissue is in the cavity that they're entering. So critical items are those devices that enter normally sterile tissues, and therefore, if we reuse them, they have to be sterilized. For semi-critical devices, devices that contact mucous membranes, such as the mouth, we don't need sterile devices. They need to undergo high-level disinfection. And then for non-critical devices, things, for example, that touch skin, only low-level disinfection is required. So we're seeing this phenomenon even prior to COVID, but especially with COVID, where we're cleaning, for those things that are reusable, we're cleaning things more than perhaps is necessary, and that also has its environmental impacts. So when we compare a reusable and disposable device, I'm going to use an example I mentioned that has been on critical shortage, which is the laryngoscope. In this case, it's a rigid laryngoscope. I mentioned the video laryngoscope. So when we do these studies, we have to describe the scope or the boundary of what's included or excluded. In here, we looked at all the emissions related to single-use disposables. We compared to reusables, both the tongue blade component that goes in the mouth, and also there's a handle that is attached to. So the same, but what the same impacts areas, raw material extraction, manufacturing. But what's different here is that we're cleaning it. So we have to consider what level of cleaning we're doing, and then ultimately how we're managing our waste. And we also looked at costs. So it is usually considered cheaper to go with disposals, but usually that's only looking at the procurement phase of management and not what it costs to actually clean and then ultimately throw away. So the entire life cycle of costs has to be considered when making these comparisons. And so just very briefly, so here is a disassembled disposable rigid laryngoscope. Here is a reusable one. Looking at the tongue blades and the handles separately and what level of cleaning. On the left is the emissions, and then just if you kind of squint at it, what stands out is that the gray is really most impactful, and that's a single-use disposable. So P is for plastic, S is for steel. There are plastic and steel components here. So the disposable are much more impactful, 7 to 9 times more impactful in the cases of the handles in particular than the reusable variants. And when we did cost analysis across our institution, we found that going to disposables would increase our costs by several $100,000 if we went to disposables. And, the argument is that this is infection control. There is no demonstration of benefit of infection control for using disposables. And others say, well, we'll recycle the components and therefore it's not so impactful. So the waste disposal management is the red bar. The error bar here is if we could 100% recycle these components, in reality, we can't. So in other words, we can't recycle our way out of our disposable problem. So another criticism is, well, we lose these reusable devices, and so therefore single-use disposables are still cheaper. So the stainless steel ones are rated for 4,000 uses. As long as you refurbish them, they can last much longer than that. But assuming 4,000 uses, the break-even costs were 4 to 5 reuses. The break-even emissions were 4 to 5 reuses. And the blade 5 to 7 reuses. And this is what the break-even cleaning times would be, when in reality it took about 90 seconds to clean either of these in total. That's from time motion studies. So if you can't get more than 5 to 7 uses of these devices that are rated for 4,000 uses, and the solution is not to go to disposables, it's to train your staff. Another example, reusable versus disposable blood pressure cuffs. And I have to wonder what Dr. Kumwenda is thinking, as she works in low-income nations, to try and have produce more sustainable products. This idea that we're throwing away perfectly good devices. So reusable device is usually cleaned with these chemical wipes and intermittently with an enzyme cleaner. The single-use disposables are used once and then thrown away, or per patient visit. And again, just squinting at this, the left versus the right, this is in multiple settings because they're used differently and cleaned different numbers of time, whether it's the outpatient clinic, ambulatory surgical procedures, inpatient wards, or inpatient intensive care units. And again, if you just squint at this, the things that stand out here are the orange and the yellow. And the orange is from the single-use disposable manufacturing, or the manufacturing phase, and the yellow is for the disposal phase. And so the single-use disposable is far worse than the reusable. And similarly, we did a study looking at this particular airway device. You can't even find reusable anymore. We looked at multiple impact categories, not just carbon emissions. And again, the reusable stood out as being superior to the disposable. Surgical textiles, so looking at gowns. So an obvious solution, why are we so dependent on disposable gowns when it turns out that there are reusable textiles? So here's a study that looked at energy looked at multiple categories and found that the disposable had 200 to 300% increase, or 2 to 3 times the energy impacts per equivalent use, 750% more, 7.5 times more solid waste, 2 to 3 times CO2 emissions, and 2.5 to 3.3 times water utilization for disposables versus reusables. So from an environmental sustainability perspective, in all these examples, we should be using reusables. And it turns out that if we had reusables, we wouldn't be so vulnerable to supply chain shock. Just a note on these studies, most of these studies were conducted in the United States. Here's a study out of Australia comparing different national energy mixes, looking at Australia, Europe, and the USA. And so we used average national mixes, meaning how much, a certain percent is renewable energy, a certain percent is from natural gas, and so forth. In Europe, which is more renewable, has more renewable energy in its mix, the reusable impacts are much lower. So in other words, the reusable impacts are that much lower. So that means the numbers I showed you would look even more favorable toward reusables than in the US. It's just the data I presented. And it would actually, because the energy in Australia is dominated by brown coal, the impacts would look much worse. In fact, sometimes favoring disposables over reusables. Now, the answer isn't that we should use more disposables in Australia. It's that we should clean up the energy and get rid of brown coal. And that is the general issue, as I mentioned at the very beginning, that the vast majority of healthcare footprint is coming from the supply chain, and the vast majority of that footprint is coming from energy. So addressing clean energy is one of the most important things we can do, as well as shifting towards more reusable devices, which also helps bolster the supply chain and protect it from shocks. So we need to ask the question, what even is a disposable medical device? This is an industry label. The SUD label came from industry. It's not a regulatory label. And basically what it means is that whoever at least this is how it started in the United States, and I think that this is similar in Europe and elsewhere in the world, that whoever cleans the device becomes responsible for the risk and responsibility of its function as if the organization were the original manufacturer. So by making this regulatory change here, it essentially started to drive the disposable movement. More than infection control, no one wanted to assume that risk. So there's nothing inherently wrong with cleaning many of these devices as long as they function appropriately. Reprocessing refers to its cleaning, whether it's done in-house in the central sterilization supply department, or whether that job is externalized by a third-party vendor. Reprocessing has come to refer to third-party vendor. Historically in the United States, industry started to push back and said it wasn't safe to reprocess these devices. And so there was a government commission report that compared devices reprocessed by third party versus those designed for reuse, and found that there was no difference. Unfortunately, only 2 to 3% of approved single-use disposable devices are reprocessed in the US, and we have been leading the world in our adoption of this industry. There's a lot more room for improvement, both in the US and globally. And so, coming back to this theme of COVID and climate change, there's this idea of resiliency. It's the same message, whether we're talking about a reusable versus disposable mask, reusable versus disposable gowns or surgical linens. In this case, this is a reusable laryngoscope, video laryngoscope, tongue blade and handle, and here's a disposable. In this crisis, we've been reusing everything. So we had to figure out how to clean these N95 masks. We had to figure out how to clean these single-use disposables. We had to figure out how to clean gowns. and in particular the contact precaution gowns, which are very difficult to recover and clean, really not worth the effort, really an act of desperation. And now we're cleaning these quote unquote single-use disposable covers because we don't have a choice. So whether we're reprocessing a reusable or a single-use disposable, both as we've learned from the approved industry and as we've learned from our own desperate measures in our own institutions, these devices can be cleaned and can be used safely. So it begs the question, and what is the difference between a single-use disposable and a reusable, other than how it's regulated and its durability and design? So we need to design better for reuse, and that's part of our supply chain resiliency solution. So I know there are other talks about the circular economy. So, in healthcare, as other industries, we tend to have this take, make, waste, or linear economy where materials are extracted, manufactured, used, and eventually thrown away. People are aware of, we've talked about reusing devices. We just talked about reprocessing them. They can be repaired and refurbished and repurposed for other purposes. So, for example, sterile gowns used for surgical procedures, when they're no longer viable for that use, can be used for non-sterile procedures. And then recycling is a low-level solution, but one that should not be ignored, but it is low down on the list. And then importantly, we need to redesign our materials to break the chain of disposability. These are all principles of the circular economy, for which you will have talks on later in this meeting. And some of those principles includes ultimately reducing the demand for these materials, selecting less material when we make them less energy intensive, design them for reuse, extend their life to recover materials, design out harmful environmental emissions. So these are all principles of the circular economy. And as we come to a close, as we know, the Intergovernmental Panel on Climate Change special report that came out in 2018 ultimately said that in order to not even achieve the business as usual is going to take us to 5 degrees, nearly 5 degrees centigrade warming, which is not sustainable for human civilization. In order to abate this, the Paris Accord pledges are here. Current policies are not even close to where we need to be. But in order to avert the worst public health harms from climate change, we've got to make dramatic changes to how our economy runs, and ultimately get to 45% emissions reductions by 2030. That's 10 years from now. There's this misnomer that we're all going to die in 10 years if we don't stop climate change. It's not what this is saying. This is saying that in order to slow down the rate of warming, to give us a chance to reduce it, and to adapt, we have to reduce our emissions by 45% by 2030, get to net zero by 2050. It is possible. We have the technology. What we lack is the political will. It's the same concept of flattening the curve. The world has come together. So with the surge of patients with COVID, the concept of flattening the curve is, can we use social or physical distancing? Can we wear our masks in community? Can we wash our hands better? All these procedures together have slowed the rate of adoption, or slowed the patients served to stay within our health system's capacity. So we exceeded this capacity in New York City. We exceeded this capacity in Lombardy, Italy, and other parts of the world. I'm very grateful at my own institution. We were able to flatten the curve, so we were able to address the needs, which were quite severe in our own communities for COVID. And whether we're talking about a COVID or climate change, the concept of flattening the curve is the same. We can do it. We've proven we can come together to do it globally. And compared to the COVID pandemic, 10 years is plenty of time to do what needs to be done. Thank you.
Thank you very much, Jodi, for that presentation. Very interesting. So we have a little bit of time left that we're going to spend for questions. So I'm just going to have a look in the chat and see if there is any questions for Rosemary or Jodi. I can see that Rosemary has already answered a few questions, which is great. Thank you, Rosemary. We also have a question directed to Jodi that I will read to you. Reusable, disposable studies are interesting, but what do you use for price fresh water per square meter and energy kilowatt hours and salary per hour? This varies country by country. In Finland, water costs roughly 6 euros per square meter, energy 0.2 euros per kilowatt hour, and labor 40 euros per hour.
Well, thank you. It's a really great question. And so I failed to emphasize that these studies need to be reproduced in the local context. So when we did our these studies, for example, the studies out of Australia really replicated our findings in terms of the time required to do the cleaning. So you have to put in your own labor calculations. For us, it's about $50,000 per annum for a central sterilization supply expert. In terms of the cost, we know per load and how many devices go on a load, how much water, how much chemicals, how much energy. So you have to input your local data. Water is a fairly tricky thing to calculate, not so much in reusables because you know how much water is going into each cycle. Cleaning cycle, where it gets complicated is in the manufacturing phase because there's a lot of uncertainty in how much water goes into natural resource extraction and manufacturing procedures. So the only study I showed that showed water data was the one looking at surgical linens, and that was actually a review article of many studies. I can't tell you if any of those were done in Europe. I don't think that was the case. So, but these can be reproduced locally. But I will say that the consistent theme is that it is cheaper to use reusables, and it is less energy intensive to use reusables. In general, in Australia, I gave an example where depending on the device, it's slightly more favorable to use disposables. But again, the solution is to improve the energy. In terms of cost, that's something you'd have to reproduce locally. Certainly what it costs us to buy a disposable is when we look across the organization, it is cheaper to use reusables. The problem is when administrators look at siloed costs. And I invite our Finnish colleagues to reproduce these studies, and that would be very important.
Great, thank you for that, Jodi. We're just going to leave a couple of minutes for participants to be able to write a question in the chat if they have any. Please specify if you want to ask Rosemary or Jodi a question. So we're just going to leave 2 minutes for that. In the meantime, I can inform you that all the sessions today are being recorded and will be available after the conference. So if you are missing a session that you would like to see, you can see it after the conference. Let's see, I think we have a question for Jodi. You talked about the reduction of infection during the last century. Has the introduction of single-use plastics not played a role in this? Isn't there a risk of infections if we go back to multi-use of medical devices?
Another great question. So there are always human factor elements, but that is true whether we're talking about reusable versus a disposable. I will tell you, for all the cases that I presented, they came with careful review of the literatures. It's nearly impossible to do a randomized placebo-controlled trial, which is the gold standard, comparing a reusable versus disposable device, because infections are multifactorial in nature. But there are plenty of case reports, case series showing infection transmission even from a disposable device. So just because something is disposable does not mean that it cannot transmit infection. It has to be handled properly. And for those devices that are difficult to clean, for example, and very expensive to recover, so for example, small plastic tubes for intravenous catheters, it doesn't make sense to collect those. Gloves, it doesn't make sense to collect those unless you have no supply chain source. In those cases, it would be better from an infection control perspective and an environmental perspective, not necessarily a social perspective, but in environmental and infection control and cost perspective to use disposables. So it's not always the case that disposables are bad, but we're going toward disposable everything in wealthy nations, from complex surgical devices to something as simple as a blood pressure cuff to patient pillows and linens. And to answer the question about plastics, plastics started being introduced. First one I'm aware of is in the 1950s, but really didn't start catching on until the 80s. And from that slide I showed you, there's not been a notable decrement in infection rates from the introduction of plastics. So perhaps there is, but does it outweigh the harms that are being wreaked by the environmental emissions? And, you know, I forgot to mention life cycle assessment does not capture the macro harms from plastics, so clogging of our waterways and our animals' guts and the accumulation of the microplastics. The chemicals are accounted for in the ecotoxicity and human health impact categories, but some of the larger impacts from plastics are not even captured in life cycle assessments. So, you know, what about those damages and that trade-off? So plastic is great. Too much plastic is a problem.
Great. Thank you for that, Jodi. With that, we now have to conclude this plenary introduction. The next session will start in about 15 minutes. So I would like to give a big thank you to Sam Kondo Steffensen at DTU and Daniel Eriksson at NCSH for their presentations. And of course, a really big thank you to Dr. Jodi Sherman and Dr. Rosemary Kumwenda joining us online. Thank you very much.